In addition, our latest Addiction Evidence Project report focused on the impact of addiction on children, youth, and families. And this report provides policymakers and other stakeholders with the information needed to take stock of Ohio's policy response to the addiction crisis. It also highlights opportunities for improvement where policy solutions can make a difference for children impacted by addiction. Today, we're going to explore key findings from both of those reports. I want to thank our Addiction Evidence Project Advisory Group members, as well as our ACEs Impact Project Advisory Group for their contributions to this work, as well as our funders for these projects who make the work possible. Before we dive into the research, I'd first like to introduce Christy Burr, who is now serving as the Director of Children's Initiatives for Governor DeWine. Director Burr is going to provide us with a brief update on the priorities and initiatives that the state is engaged in to address childhood adversity and the impact of addiction on our young people. So with that, Director Burr, take it away.
Hello, good afternoon, everyone. Thank you for the opportunity for some time to kick us off today. Again, my name is Christy Burry, and I'm actually now the Director of our Office of Children's Initiatives with the Governor's Office. And so I know the slide says Children's Services Transformation. There have been some recent adjustments over the last several weeks that perhaps many of you have heard about, but Leanne Cornian was serving in the capacity within the Governor's Office for the Director of Children's Initiatives. She has moved into another role within the Governor's Office, but she's not far. I'm still working really closely with her with all of our children's initiatives work across our state agencies in the kids space. For the last 2 years, though, with the administration, I have been knee deep in the Children's Services transformation work and leading the Governor's Children's Services Transformation Advisory Council. And that report and those recommendations were just issued at the end of the year, and now we have moved into implementation, and that's implementation work in the context of everything else happening with Family First and Ohio Rise. Just there's a lot happening, and a lot of it really interconnects. And then prior to that, I was at the county level, so county government was for almost 20 years, back and forth between Franklin County Children's Services and Fairfield County JFS. Started out as a caseworker in Franklin County, and eventually, before coming to the state with this administration, was serving as the Child and Adult Protective Services Deputy Director in Fairfield County for about 6 years. So that's just a little bit about me. I wanted to mention that. Knowing that we have made some of these changes in recent weeks. I'll start off. I'm just going to highlight some of the broad children's initiatives priorities with the governor right now, especially in the context of the budget process happening right now. Even with some of these changes that I'm mentioning, the vision of the governor remains the same as it has been from the very beginning. That was charted in the Opportunity for Every Ohio Kid plan, and that will continue to be our priorities moving into this next biennium. And I feel that the budget really demonstrates that. And if you want to move to the next slide, I've just thrown some of those priorities that I'm sure many of you already are aware of, that have been priorities, will continue to be a priorities. It's really about taking it to the next level, and all of the work with children's initiatives revolves around maternal and infant health, maternal and infant mortality reduction. Our Eliminating Disparities in Infant Mortality Task Force just kicked off yesterday. And the great thing about this is kind of modeling that off of the Children's Services Transformation Advisory Council and all of the listening sessions and community work that was done by the task force prior to even thinking through what the concrete recommendations were going to be. It was about listening to the voices of those directly impacted, so that over the next couple weeks, that no, couple months. We'll come back together the end of May. The task force will be doing a series of community listening sessions, listening to Black families and Black women to share their expertise and experience to really inform that process. So we know that that's going to be a big piece of work in the upcoming months. Of course, continuing to prioritize tripling the number of families served by home visiting. The budget includes some expanded eligibility opportunities, and increasing the reimbursement rate to align with as it relates to moving up to the 25th percentile for the market rate. And you know what? I just skipped to childcare. That was childcare. Obviously, home visiting, our work there, especially in maternal infant health, is increasing the number of families served as well there too, through home visiting, through our 3 evidence-based home visiting programs in Ohio. And that work's exciting too, because it's linked to our Family First Prevention Services Act implementation work on the children's services side of things as well. Early childhood intervention continue to be the priorities. This obviously is really relative to our work revolving around child health and those priorities related to neonatal abstinence syndrome, and also, with that, wanting to reduce substance exposed infants. But for early intervention, ensuring that our kids with those documented diagnoses are linked early with those early intervention services. Reforming the Children's Services foster care system, and I'll talk more about that and highlight some of those pieces. And then, of course, our youth social and emotional well-being priorities revolving around prevention education and wraparound supports, school-based health services, access to mental health professionals. This really revolves all around our student wellness and success funding, and is going to continue to really be important as we move into this next biennium. And then the last thing that's not on here is, really this other category of housing, and that when we think about housing, that's really where all of the priorities revolving around lead poisoning prevention. This was a priority up until this point, but moving forward, wanting to having some clarity with what that next phase of work is going to look like, and the need for increasing some of those investments to continue to work on that. But then also ensuring that we're developing a cross-agency housing response in general as it relates to our work in the Children's Initiative space, which also includes youth homelessness, of course, recovery housing, and what have you. So I just wanted to start off just by overarchingly mentioning some of those broad priorities. I know that we don't have a lot of time today to go through all of the details of the budget. So I wanted to start off by just broadly mentioning those. The next slide then is just making sure that we're prioritizing, I'm prioritizing all of the critical work and important partnering that are across our agencies in this space. So Department of Ed, Department of Developmental Disabilities, Medicaid, Mental Health and Addiction Services, Health, Job and Family Services, DYS as well. We've really established kind of an infrastructure to ensure that we're working toward cross-agency alignment and growing programming and planning for vulnerable children and families together. And so there's been a lot of work in that area. We've really, the deputy directors and assistant directors of each of the agencies are very involved in this process and have been working really closely with Leanne over the last couple of years, and then that collaborative work will continue. The next few slides, and I'm probably not going to have time to go through these because I want to end with some more specific things specific to children's services, but I'm assuming that you might get copies of these slides, are just some of the highlights for the budget. So if you move to the next slide, I know that I'm assuming most of you already have access to the budget that was released and where the priorities are. We've just put some examples here on the slide of things that stand out most. all of it's important, but wanted to try to narrow down some items for all of you today, revolving around paying attention to home visiting and infant mortality reduction, those line items to continue expanding our home visiting. We are now in 86 of 88 counties. So 86 of the 88 counties now have access to an evidence-based home visiting program. And I think it's Delaware and Union are the last two counties, and they're slated to have that access by the end of June. I've already mentioned Help Me Grow Early Intervention and the priorities revolving around that. Infant vitality, and just an example here of focusing on some grants for faith-based and community-based providers working to improve outcomes for pregnant mothers and children. And then part of that also includes universal needs assessments. Housing pilot is identified in the budget, a collaboration between DSA and ODH to really focus on the housing needs to improve maternal and infant health. And then we have our Medicaid priorities. The next slide then highlights some of the proposed investments with multi-system youth. This has been, I've been around for a while, and this has been an ongoing need for years and years and years to better meet the needs of our children and families who are trying to get access to care and resources at a community level. So continuing the $25 million each fiscal year to the PCSAs, which a portion of that also is going to the Family Children First Councils at a local level. Our multi-system youth custody relinquishment fund is at $16 million each fiscal year, and this is a continuation of this new state program that we put in over the last couple years. This is such important work. Over 90% of the children that have been involved in the state program have been able to stay with their families, and we haven't had to relinquish custody, and that is critical and important to think about that. And then with developmental disabilities, there's a new investment, just moving funding around to prioritize our multi-system youth work, knowing that as we've worked through the state program, almost 50% of kids have some type of diagnosis with an intellectual or developmental disability. So making sure that we're prioritizing the needs of those children with developmental disabilities at a local level. So this would include respite and telepsychiatry, access to multidisciplinary teams of experts. So thought that this would be an important area to highlight for this group today, especially knowing what the reports that are going to be highlighted. And then the last one here then to highlight out of everything is for the next slide is Children's Services transformation. And there's been a lot of work in this space. We're very lucky that we have an administration that is prioritizing our work with Children's Services, and this kind of identifies some of those investments here. Also includes the continued and additional investments with our 30 Days to Family work that's happening throughout the state, Ohio Start, and I'll mention more about that in a moment, foster care recruitment, Children's Services best practices, Kinship Navigator program, and then some of these new investments are absolutely critical because we've gone through this entire process to identify the key priorities across the children's services and foster care system that need to be addressed in order to move toward real actionable change. And some of those recommendations in the report will require some new investments in order to move those forward. So this, and again, I know you have access to all of this, but this will be these will all be important as we move forward. So $10 million to establish a kinship guardianship assistance program, $1 million for the university partnership program, $10 million for evidence-based prevention programs, and this is really going to allow us to expand our work and for implementation for Family First. State level foster care ombudsman, up to $12 million a year to expand Wendy's Wonderful Kids, and then ensuring that we have the right capacity for adoption. Those that are able to do our home assessments and ensuring that we have the right capacity for foster and adoptive families. And then this last slide, because I know that I'm running out of time and I've just been told too that my video is not on, so I apologize for that. My video is always on. Those of you on here that know me know that. So it says it's on to me, but it's not. So sorry about that. But this last slide was just to highlight, and I don't think that we'll have much time today, but these were the things that if there are any follow-up opportunities or with the topics that you're going to talk about today, these are priorities across the state that I think really align with addressing trauma. I mean, all of this does, obviously, but the trauma, the impact of ACEs, our Ohio Start work is now going to be in 52 counties, and this evidence-based intervention is really focusing on families struggling with abuse and addiction while trying to parent and making sure that we're wrapping around a team of caseworkers and family peer mentors, behavioral health providers to support them. And we know that with intensive services and supports, parents can overcome addiction and children may be able to remain safely in their home or may be able to be reunified as part of their recovery. So this is really important work. Of course, I mentioned Family First Prevention Services and why this is so important to our work with best meeting the needs of our children, especially those who have experienced trauma, as it relates to more, if kids need more residential type care, that it's of quality, it's trauma informed, and that we're focusing on prevention. We have the Trauma Informed Care Certificate that has been launched recently to ensure our professionals that are interacting with kids and families are not just aware, trauma aware, but it takes them through a series of certificate levels to also become trauma informed and then trauma competent. And then I mentioned multi-system youth, and then the new announcements related to the new Child and Adolescent Behavioral Health Center of Excellence is an important piece of work that our cross-system partners have really put a lot of work into getting us to this point, and issued a joint RFP in Case Western University. Their Center for Innovative Practices was just announced, and we're going to be moving forward with that work to help the state in the system transformation that really needs to happen. So that is it. I'm going to stop there. I know that I may have started a couple minutes late, so I don't want to use up too much of your time going into your next topics, but just appreciate the opportunity to join and share a little bit today about some of our priorities. So thank you.
Thank you so much, Director Burry, and I apologize for mispronouncing your name during my introduction. We're so thankful that you were able to take the time to be with us today. I am not seeing questions for you at this time. There's a comment that we'll pass on to you offline. But if there are any other questions for the director, feel free to type those in the chat, and we'll make sure that those get sent along. But not seeing any at this time, we'll just keep it moving to my colleagues Reem and Carrie. Reem is Vice President at HPIO, and Carrie Almasy, oh my gosh, I'm so sorry, Carrie. Carrie Almasy is a Health Policy Analyst at HPIO, and they're going to be presenting some of the key findings from our ACEs Impact Project. So with that, I think I'll hand it off to Reem.
Good afternoon. Thank you, Haley, and thank you, Director Burry, for that overview. We look forward to continued leadership as the director now of the Governor's Children's Initiative. And what Carrie and I will be sharing today is going to be focused on these three key findings or key takeaways, and they really build on the necessity of all of the different strategies that Director Burry has shared that the state is taking. Just to set some context for our presentation this afternoon, there is variation among researchers in what is considered an adverse childhood experience. However, ACEs can generally be grouped into the three categories that you see here, which is abuse, household challenges, and neglect. Unfortunately, exposure to ACEs is a significant problem in Ohio, and Ohio is actually in the bottom quartile, ranking 39th out of 50 states and DC on the percent of children who have been exposed to 2 or more ACEs. In 2020, HPIO launched its Ohio ACEs Impact Project, which was incredibly timely and important prior to the pandemic, and is unfortunately even more crucial to focus attention on today in the current environment. The project builds on other state and local initiatives by producing a series of 3 briefs and a resource page to provide actionable data and information that can then help to inform a comprehensive policy approach to prevent and mitigate the impacts of ACEs in Ohio. This project is informed by a multi-sector advisory group with state and local experts from across the state and is funded by, in part by the Ohio Department of Mental Health and Addiction Services, supported by Ohio's 2020 to 2021 SAMHSA Community Mental Health Block Grant, the Harmony Project, the Ohio Children's Hospital Association, Interact for Health, as well as HPIO's core funders. In August, we released the first brief in this project focused on the health impacts of ACEs. We released the second brief in February, providing new analysis on the economic costs of ACEs in Ohio. And we anticipate the third brief, which will be focused on strategies to prevent and mitigate the impacts of ACEs, will be released this summer. However, we'll be sharing key findings from these first 2 briefs this afternoon with all of you. And HPIO contracted with Ani Ruhil from Ohio University Voinovich School of Leadership and Public Affairs and Christelle Chala from University of Wyoming to provide analyses for these 2 briefs. The first key finding, which is not going to be a surprise to you all that are on this webinar, is that exposure to ACEs is a pervasive problem among children in Ohio. Children in Ohio are more likely to experience adversity and trauma, as I shared earlier, and this data provides a sneak peek at HPIO's biennial 2021 Health Value Dashboard, which will be released in April. And the data from the dashboard shows that Ohio's ranks in the bottom half of states on experiencing 2 or more ACEs, child abuse and neglect, and poverty. Through our analysis, we found that nearly 2/3 of Ohioans reported that they had been exposed to ACEs, with more than 1/3 of Ohioans reporting that they had been exposed to 2 or more ACEs. This table provides prevalence data by each specific ACE, and among the nearly 2/3 of Ohioans that have been exposed to at least one ACE, more than half experienced emotional abuse, followed by 41% who were exposed to a household member with a substance use issue. Over the past year, the link between racism and health has really been at the forefront of public discussions. And the research is clear that racism is a primary driver of the disparities and inequities experienced by communities of color. There is also a growing body of research connecting racism and other forms of discrimination to ACEs, to experiencing trauma and toxic stress. On the left side of your screen, you see that compared to white children, parents of Black children in Ohio are 17 times more likely to report that their child was treated unfairly due to their race or ethnicity. And what that means is that 1 in 10 Black children in Ohio are being treated unfairly due to their race. On the right side of your screen, you can see how experiencing racism directly impacts health and can have longer-term consequences, with Black adults in Ohio being more than 5.5 times more likely to report physical or emotional symptoms as a result of treatment due to race. And that is 1 in 5 Black adults in Ohio. Exposure to stress and adversity early in life is incredibly harmful. And the Centers for Disease Control and Prevention framework explains how risk and protective factors experienced early in life influence health and well-being across the lifespan. And this framework acknowledges that children are impacted by the structures and environments in which they live, and societal factors, including the generational impact of experiencing trauma and exposure to poor social or community conditions. Notably, Ohio also ranks in the bottom half of states on several risk factors for ACEs, shown here. So for example, Ohio ranks 47th out of 50 states and DC on drug overdose deaths, which suggests that children in our state are at greater risk of being exposed to substance use by a household member, which is just one type of ACE. Now, I'll turn it now over to my colleague, Carrie, who will talk more about the health impacts of ACEs on Ohioans.
Thank you, Reem. As explored in HPIO's brief, Health Impact of ACEs in Ohio, there is well-established research connecting ACEs exposure to poor health and well-being throughout adulthood. Consistent with national research findings, Ohioans who reported experiencing more ACEs were also more likely to report having depression, chronic respiratory issues, smoking or drinking heavily, and delaying healthcare in the past year because of cost. As you can see in this figure, the percent of Ohio adults who are current smokers and experienced 2 or more ACEs, or 32%, was almost 3 times higher than adults who reported no ACEs, at 11%. The same is true for adults with depression. To understand the extent to which preventing ACEs could improve the health of Ohioans, we turn to a tool called PAR, or Population Attributable Risk. PAR is an estimate of the percentage of an outcome observed in a population, such as depression, that can be attributed to a specific factor, like exposure to ACEs. In our analysis, PAR provides an estimate of the percentage of negative health outcomes in Ohio's adult population that can be attributed to Ohioans who experienced multiple ACEs. So the figure we display here illustrates the PAR, or impact of preventing ACEs, on 6 health outcomes. As an example, it shows that an estimated 36% of depression diagnoses in Ohio can be attributed to experiencing multiple ACEs. Another way to think about this is that if exposure to ACEs were eliminated among all Ohioans, an estimated 36% of depression diagnoses could also be prevented. One of the goals of HPIO's analysis was to better understand which ACEs have the most significant health impacts on the health of all Ohioans. So to that end, we found that the ACEs you see here with the red boxes have significant health impacts for Ohioans. These ACEs that are impacting Ohio's children directly are also driving long-term health and economic consequences across the state. And we'll go into that in a little more detail in a moment. But first, I wanted to share this graphic, which shows the extent to which certain health outcomes could be avoided if a specific ACE were eliminated. So as an example, if exposure to emotional abuse were eliminated, an estimated 16% of depression and 12% of current smoking could also be eliminated. Oops, went too far. There we go. Beyond health impacts like depression and smoking, ACEs exposure results in direct and indirect cost to individuals, families, and society at large. HPIO's second briefing in the series really explored the economic impact of ACEs and what this means for Ohio. There is emerging research linking ACEs exposure to costs incurred across the lifetime. So this figure summarizes study findings on the average per person lifetime cost of child maltreatment, otherwise known as abuse and neglect, in the United States. For each person affected, lifetime costs are estimated to be over $830,000 in child welfare, criminal justice, and healthcare costs, as well as reduced quality of life. To provide an example of the economic impact of ACEs, we can turn to the child protection system. So we know from the research that experiencing ACEs increases the likelihood of child protection system involvement. Children typically become involved with the system after a report of potential child abuse or neglect by a parent or caregiver. In Ohio, public children's service agencies, or PCSAs, are responsible for providing child protective services to children and families. And we know that in 2018, Ohio PCSAs screened 101,243 reports of child abuse and neglect, household substance use, and families in need of other services. Costs associated with the child protection system stem from things like investigating potential causes of abuse and neglect, finding permanent and temporary placements for children, and providing support and assistance to families. So this is just one way that ACEs play out in terms of the economic impact in Ohio. Beyond the child protection system, the costs associated with ACEs are incurred across the public and private sectors, including Ohio's behavioral health, criminal justice, and Medicaid systems. ACEs and the poorer health outcomes they cause are important contributing factors to the cost that we display here, which are borne more broadly by Ohio's communities beyond those who are directly affected by ACEs. We also know that some of these communities bear a higher proportion of these costs than others. As discussed in our first brief, health impact of ACEs in Ohio, Ohioans of color, Ohioans with disabilities, Ohioans with low incomes, and those who live in urban and Appalachian counties are more likely to experience multiple ACEs. Here, we show that Black Ohioans are 1.8 times more likely to experience 2 or more ACEs than white Ohioans. Likewise, children with special healthcare needs are 2.1 times more likely than children without special healthcare needs to experience multiple ACEs. So now I'm going to hand it back over to Reem to walk you through our analysis of the economic impact of ACEs in Ohio in more detail.
Thanks, Carrie. So we wanted to build on the national research findings, and so we conducted an assessment of the economic impact of ACEs specific to Ohio. And through this analysis, we estimated that Ohioans spend more than $36 billion in healthcare costs related to the treatment of depression, asthma, COPD, smoking, as well as excessive drinking on an annual basis. And approximately $10 billion of this annual cost is actually attributable to exposure to ACEs. So it's $10 billion a year attributable to ACEs for treating these specific conditions. Estimates of annual costs attributable to ACEs exposure for asthma, COPD, depression, smoking, as well as excessive drinking ranged from $625 million to $4.5 billion. You can see in the table here, with the cost for treating depression attributable to ACEs exposure totaling more than $4.5 billion per year. We also estimated the extent to which ACEs exposure contributes to lost productivity in Ohio through lost wages due to missed work days. And annual lost wages attributable to ACEs totaled nearly $300 million for depression and $21 million for COPD. One of the primary objectives of this project, as Carrie had highlighted, was to get a better understanding of which ACEs have the significant impacts on the health of Ohioans, and primarily because we know that not all ACEs are equal in their impact. And what we found, as Carrie shared, is that the ACEs you see here not only have significant health impacts, but they also are driving significant economic costs in Ohio. So for example, we found that 16% of depression diagnoses in Ohio are attributable to emotional abuse during childhood. And this translates to $2 billion in annual spending to treat depression. And then similarly, 1.9 billion can be attributed to experiencing sexual abuse. As another example, we found that $2.5 billion in annual spending to treat depression and $500 million to treat asthma can be attributed to being exposed to a household member with a mental illness. Just to recap, based on our analysis, we found that more than $10 billion a year in healthcare spending and $319 million in lost wages could be saved if ACEs were eliminated. If we were successful in avoiding even 10% of the costs attributable to ACEs, that would amount to more than $1 billion in spending that could be saved each year, specific to these lost wages and health conditions. So this is really a conservative estimate of what could be saved if we were successful in reducing exposure to ACEs in our state. The COVID-19 pandemic has resulted in what are unprecedented health and social and economic challenges for all Ohioans. And today, we are releasing a fact sheet for all of you on the impact of the COVID-19 pandemic on ACEs. So I think Alana is going to drop a link to that fact sheet. You guys will have the first look at that in the chat box, and then we'll also share a link in our follow-up email to you after this webinar. And I just wanted to highlight a few key findings from this fact sheet. We found that the impact of COVID is translating into likelihood of increased exposure to someone in the household having a mental health condition or issue. And so the U.S. Census Bureau Household Pulse Survey found almost 4 in 10 adult Ohioans had reported symptoms of anxiety or depressive disorder since the beginning of the pandemic, and that's comparatively compared to 1 in 10 adults that had experienced the same symptoms between January and July 2019. So we went from 1 in 10 to 4 in 10 in the midst of this pandemic. Preliminary data from 2020 shows that the drug overdose death rate has increased by 15% in Ohio compared to 2019, which actually reverses a downward trend in the overdose death rate that we had seen more recently. At the same time, we have seen that alcohol sales by gallon have spiked during the pandemic and have grown by nearly 10% from 2019 to 2020. And then in fiscal year 2020, there were 109 people that died because of domestic violence, with the youngest child victim being just 2 years of age. And this is a 35% increase from fiscal year 2019. We also know that during this pandemic, many Ohioans have been exposed to what would be considered some pretty critical risk factors for ACEs, including economic hardship, things like experiencing housing instability or being unemployed, and social isolation. Just as an example, we know that Ohioans have experienced increased unemployment rates, foreclosures and evictions during the pandemic. And in addition to that, the implementation of public health measures that were necessary to mitigate and prevent the spread of COVID-19 have contributed to existing social isolation in our state. The data and information that we've shared highlights the need for a comprehensive approach to prevent and mitigate the impacts of adversity and trauma on Ohio's children. And this includes tailoring strategies and allocating resources to our communities that are most at risk for experiencing ACEs, or our children that are most at risk for experiencing ACEs, and then focusing on strategies and supports that have co-benefits, strategies that can impact multiple ACEs, and that can prevent and mitigate the impacts of ACEs. Prioritizing the prevention of ACEs that we found to have significant health impacts, which were emotional and sexual abuse, living in a household with someone who has a substance use disorder, mental health problem, or who is incarcerated. I know we reviewed quite a bit of information, Carrie and I, so you are welcome to go to our website to review our data and policy briefs. We also have several shorter fact sheets on the health and economic impact of ACEs, and as well as this new fact sheet that you now have on the impacts of COVID-19. And then we have additional information that can be found on our ACEs resource page, which we will continue to update throughout our Ohio ACEs Impact Project. And if you have any questions about the information Carrie and I covered, you can find our contact information here. And we are, I think hopefully we have some time to answer a few questions if you have any.
Thank you so much, Reem. I have just seen one question come in while you've been presenting. And the question is about considering racism as an ACE. So have you seen any movement at the state talking about considering racism as an ACE, or any data sources or research that has talked about that?
Yes, so right now the National Survey of Children's Health does include experiencing racism, children's parent reporting of children experiencing racism as part of its set of adverse childhood experiences. And I know that there has been discussion among state agencies about the impact of racism as well as other forms of discrimination and how it contributes to adversity and trauma and can be considered an ACE. So there's certainly been discussion, and I think likely going to be more concerted attention and effort to address this going forward.
Great, thank you so much. All right, we're going to keep it moving right along. We are now heading into our last presentation of the afternoon. Now would be a great time, since we've been going for a little while, if you wanted to sort of stretch in your seat or stand up and march in place if you're able. We have one more presentation for you. Want to keep our energy up and blood flowing. So I am now going to introduce two more of my fabulous colleagues. Jacob Santiago is an assistant health policy analyst with us at HPIO, and Amy Bush-Stevens is a vice president at HPIO, and they're going to take us through the key findings of the latest Addiction Evidence Project report on children, youth, and families. Take it away, Jacob.
All right. Thank you, Haley, and good afternoon, everyone. Before I begin, I would like to extend some gratitude to the Addiction Evidence Project advisory groups, as well as those who are funding the project, including Interact for Health and the Ohio State Bar Foundation. This afternoon, my colleague, Amy Bush-Stevens, and I will take you through the scorecard on children, youth, and families. I will be covering the context and some background information, and then Amy will take you all through the key findings. The overdose death rate has been a large topic of conversation over the past several years, and for a good reason. In 2017, 4,853 Ohioans died from unintentional drug overdose. This is a historic high for our state. Along with that increase in overdose deaths, we see an increase in the number of children being taken into the custody of PCSAs. This trend has continued to rise even after overdose deaths fell below its 2017 peak. We also see an increase in the number of children removed from their homes, with the reason being for parental substance use. Thus, more children are being exposed to trauma in childhood and leading more youth to experience those poor health and economic outcomes discussed by Carrie and Reem. Additionally, the number of newborns with a prenatal exposure to substances has sharply increased over the past decade. In 2016 alone, over 2,200 newborns were discharged with a prenatal exposure diagnosis. This is yet another high for our state. However, there are ways to limit these impacts of addiction on families. In order to assess Ohio's progress in implementing these evidence-informed strategies that would limit addiction's impact on children, youth, and families, HPIO focused part of our addiction evidence project on this topic. We started the project back in 2017 with the release of the project overview and have released about one report per year since. The report on which we are focusing today is the fourth in the series and was released in November of last year. The goal of the Addiction Evidence Project is to provide policymakers and other stakeholders with the information needed to evaluate Ohio's policy response to the opiate crisis and accelerate and continually improve strategies to address substance use disorders in a comprehensive, effective, and efficient way. Part of that is by using the framework on the screen here. This framework for the Addiction Evidence Project displays the complex web of systems and sectors involved in addressing addiction and its impacts. Each of these areas in the framework has been addressed over the course of the project, and an advisory group of experts from a variety of sectors has aided in the development of each of these reports. Every phase of the project is made of 3 steps, an overview of which is on the screen now. The takeaway is that for each scorecard report, we look at the evidence for what works to combat addiction, compare that to an inventory of what Ohio has done, and then develop a scorecard to show the strengths, gaps, and opportunities for improvement in Ohio's policy response to addiction. Over the course of the project, as you can see on the screen, we have compiled 30 opportunities for improvement after extensively reviewing over 250 evidence sources and over 460 policy changes in Ohio. Now let's focus in on some of those policy changes as they relate to children, youth, and families. This bar graph shows the number of state-level policy changes from 2013 to 2019 related to this topic. You'll see that of all the changes made during this 6-year period, most of the attention has been focused on prenatal drug exposure, child protective services, and treatment and recovery for parents. There was less focus on other strategies such as family-focused prevention. Amy will talk more about these gaps and strengths when we get into the key findings of the report. Now, taking all of these policies into account, as well as the evidence sources that we reviewed for this scorecard, we received input from our advisory group and other public and private stakeholders to ensure that we understood how strategies for improving outcomes for families are really being implemented in Ohio. Based on all of this information, we were able to rate the subtopics within this report as either having strong, moderate, or weak evidence alignment and implementation reach. As you can see in this brief summary table, while Ohio has been successfully implementing evidence-aligned strategies across the state such as some of those discussed by the director earlier this afternoon, there is still room for improvement so that more families are able to live a healthier life together. Now that we have some background on the report and the Addiction Evidence Project as a whole, I'll turn it over to Amy, who will walk through the key findings from the scorecard.
Thank you, Jacob. Good afternoon, everyone. It's great to see so many folks on the call, including some who have been involved in advising the Addiction Evidence Project along the way, and some new names as well. I'm going to talk through some of the key findings of the report. Make sure I have my slides here. All right, so here are 3 key takeaways from the scorecard report. The first is that addiction's toll on families requires a comprehensive response. As I'm sure folks on the call today are very aware, parental addiction can harm children in many ways. And Ohio has launched many initiatives to address this crisis, many of which Director Burry talked about. But there's more that can be done to keep families together, ameliorate trauma, and build resilience. The second is that we are in a hopeful moment for change. Again, thinking about all of the things that Director Burry talked about. And so now is really the time to make sure that all of these changes that are teed up are fully implemented, fully supported, and evaluated to make sure that they reach their intended outcomes. I'm going to highlight 3 opportunities for improvement that we talk about in the report. The first one here is that we need to build on momentum to strengthen Ohio's children's services system and extend the reach of evidence-based prevention. The second is to ensure that pregnant women and parents have access to treatment and recovery. And the third is to improve screening, data, and early intervention for prenatal drug exposure. Starting with children's services and prevention, this is a picture of home visiting, which is one of the approaches that has been prioritized in Ohio. As we look across all of the policy changes in this area, these are things that really stood out as strengths to us. A few examples here. There has been a great deal of work on child welfare in Ohio over the past few years. So these are some of the key changes that have happened. You can see there's been lots of activity. Some of this mentioned by the director. Several groups have been convened, including the Joint Legislative Committee on Multi-System Youth, the Foster Care Advisory Group, and the Governor's Advisory Group on Home Visitation. These are reports that were released in 2020, and they have recommendations that were shaped by input from stakeholders around the state. At the federal level, we have the Family First Prevention Services Act, which was signed into law in 2018, and it has several implications for ODJFS and for our local children's service agencies. The purpose of Family First is to keep families in the least restrictive, most family-like setting possible. So trying to shift away from foster care and congregate care settings to the extent possible. Family First places a strong focus on prevention and requires states to have a prevention plan. And Ohio's Phase 1 prevention plan includes these approaches, which mostly come from a clearinghouse of evidence-based strategies provided by the federal government. Note that Healthy Families America and Parents as Teachers, those are both home visiting models that are also supported by the Help Me Grow program. And the federal government will be reimbursing for 50% of the cost for these for families in the system. So Ohio Start was one of those programs. It's already quite widespread in Ohio. Ohio Start and Moms are 2 examples of comprehensive approaches to parental addiction. Ohio Start is led by Child Protection Partners, and the Moms program is led by healthcare providers. And the colors here reflect the implementation of these programs in phases over time, being extended to more counties. Despite these strengths, we have many gaps when it comes to children's services and prevention. Our local children's services are stretched thin. We have inequities and limited reach of prevention. So first, looking at local child protection, their caseloads rose 33% from 2013 to 2020. And local agencies report increasingly complex needs of children, rising placement costs, and burnout and turnover and secondary prevention in their workforce. And the tricky thing about new investments in prevention is that we still need to be funding the downstream services as well. So this graph from PCSAO shows the steady increase in placement costs over time. Starting this year, agencies will be implementing Family First, so they'll be focusing more on prevention. In the long run, hopefully that will help to reverse this trend. But in the meantime, Children's Services needs to be doing all of this work. So really a challenging and important time. They sort of need to be chewing gum and walking at the same time. This is a challenge that will require significant resources, only some of which are covered by the federal government. Another problem we identify is inequity in child welfare, including racial disparities. The dark blue here are the percent of children in the population overall, and then the light blue is the percent of children removed from the home due to parental substance use. And you can see the disparities, in particular for African American and multiracial kids. So this is consistent with the theme that Reem and Carrie talked about when we look at disparities in adverse childhood experiences overall. And research also shows that there are disparities by geography and income in terms of the kids involved in the system. The final gap that I want to highlight here is that not enough families are reached by evidence-based prevention. Only a minority of families are able to take advantage of these critical programs. So just a few examples here, including home visiting. So only 17% of eligible families were participating in evidence-based home V models in 2019. So this translates to missed opportunities in terms of stabilizing families and supporting healthy youth development. Next, we'll take a look at treatment and recovery for parents. Ohio has several strengths in this area. The first is that pregnant women are identified as a priority population for publicly funded behavioral health, and the second two strengths have to do with Medicaid. Medicaid expansion, along with some other Medicaid reforms, have helped to increase access to addiction treatment for parents. And I can't overstate the importance of Medicaid for this population. So there's a lot of overlap between Medicaid and families affected by addiction. So a few examples here. In 2018, 90% of newborns with NAS had Medicaid coverage. And in 2019, over 14,000 women covered by Medicaid were diagnosed with a substance use disorder within the year before their delivery. So really big numbers here. And this coverage is critical for things like medication-assisted treatment. Ohio Medicaid had some reforms in the works that were designed to further improve access for families struggling with addiction. These have been somewhat delayed by the pandemic. They intended to request federal approval to allow continuous coverage for women with SUD during the postpartum phase instead of the current 60-day cutoff. The newly passed American Rescue Plan actually includes a provision that allows states to do this for all mothers. So it's too soon to know exactly how this is going to play out in Ohio, but it is clear that postpartum coverage is critical for addiction treatment, not only during pregnancy, but that postpartum period is very important as well. Here are some of the gaps that we saw in treatment and recovery. There are few providers that offer childcare or have programs that are specifically tailored for pregnant women and for parents. And these gaps are particularly acute in our Appalachian counties. Recovery housing is another important unmet need. And this is data from a very recent study from the Cincinnati area, where they found that among 92 recovery houses, only 10 accepted women with their children. Final area that I want to highlight here is prenatal screening and early intervention. We have several strengths in this area. Hospitals are required to report NAS to ODH, so we do have data. They're not required to screen in a universal way, so I'll get to that in a minute. But there was a policy change in 2019 that allows for children under age 3 diagnosed with NAS or fetal alcohol spectrum disorders to be eligible for Help Me Grow early intervention through DD. And there are several cross-system efforts and groups that are working on these issues, partnerships with ODH, ODJFS, and there's also the Ohio Perinatal Quality Collaborative. The gaps in this area are really about consistency and standardization. I mentioned before that hospitals are required to report NAS and substance use by pregnant women, but they're not required to screen for substance use among pregnant women or NAS in a universal way. It's therefore likely that our data on prenatal exposure is incomplete, which makes it difficult to track trends over time and also to deliver timely early intervention services that we know are so important. This data here gives us somewhat of a clue of the potential data gap. The top bar shows the number of numbers from the Ohio Hospital Association of the number of women diagnosed with SUD at the time of delivery. And then the bottom number is from Medicaid. And these are not exactly apples to apples numbers because the top number is looking at the time of delivery and it's for all payers. And the bottom number is Medicaid only, and it is looking at the entire year before delivery. But the difference in these numbers is striking and gives us a sense that many families may be missed due to lack of universal screening. Here is a recap of the key takeaways that I just talked about. The one I really want to emphasize is that we are at a very hopeful moment for change. So much work has been done in this area, and there are many things that are kind of teed up. The stage is set, and we are hopeful that lots of good work will happen in the coming years to improve outcomes for our kids. Also, I know I just covered a lot of material. I encourage you to check out the full report on our website. And also to think about how you can use this information. We rely on all of you to help us with dissemination. So we encourage you to share the Addiction Evidence Project and this report in particular with your contacts, educate policymakers and other stakeholders about these issues, and partner. We really do see a need for continued and strengthened partnerships between healthcare, behavioral health, and child protection. Okay, I think we have time for maybe a few questions.
Amy, I think we're just gonna end the day. We're a few minutes past our time, so thank you all so much. Thank you to our presenters. So thankful that you were all able to join us today. I am going to just scooch us along, or have Amy scooch us along in our slide deck. I want to let you know about this webinar that's coming up here soon that's going to announce our health value dashboard for 2021. I'm going to drop the registration link in the chat so that you all can register for that. You can also get to that on our website, hpio.net. We have a poll question for you before you close out for today. Alana's going to launch that for us. How would you rate the webinar overall? We really appreciate your feedback. We're always hoping to make improvements and deliver the best possible events for you all. So thank you. Thank you for answering this poll question for us. Our hope is that all of this work is helpful to you in your efforts to influence policy and to improve health and well-being for children and families in our state. And there are lots of ways that you all can influence policy, both in your organization and with as a private citizen. Here are some examples of what that could include. And so with this in mind, we're going to ask you one final poll question, which is, are you likely to use this information to influence the policymaking process? So again, influencing of the policymaking process can include educating legislators, influencing state agency priorities or decisions, making policy recommendations, lobbying for specific legislation, any of those sorts of activities. If you do not do any of those activities, go ahead and skip this question. But for those of you that's part of your work, we'd appreciate your response here as well. This is helpful for us in our evaluation efforts. Thank you again to all of you for joining us today. That is it for us, and we hope you have a great rest of your week. Bye-bye.